Now I pretty much know how to deal with sleeve and OAGB patient when they come back to us. Now I would like to invite Dr. Carlos Abril from Cleveland Clinic to tell us what are the revision options after Roux-en-Y gastric bypass.
I need this. Thank you very much. Yeah. Oops. I'm gonna do this. I'm gonna do this. I know you're tired, all of you. I get it. Is it going? Good. First of all, 30 seconds only to appreciate your presence here. I want to say thank you to all the committee that really overtake care of me my first time in Pakistan. I hope not the last. And thank you for all for attendance, because you are suffering us from the very beginning. The presence of all of you, technicians, thank you. You've been here all the time, so thank you very much. And I'm sure I'm gonna leave someone behind. Thank you, Javed, for being a friend. Thank you, all of you. And thank you, Ridwan and Shizan. They overtake care of me, and they always on top of me to be everything safe, everything secure. I jeopardize a couple of things, but he's been always on top of everything. Thank you very much. I'll try to be fast, but I'm not going to say that because I'm not always fast at all. So redo after sleeve gastrectomy, what to do. So many of the things that we've been talking about, they've been already mentioned. Of course, this is Angrisani slide. Everybody knows that slide. It's so old that I put something more, a bit newer, like 2021. Sleeve is the most frequent surgery performed. Gastric bypass now is the second one, but don't forget that gastric bypass once upon a time was the most frequent one. So there are a lot of patients with Roux-en-Y gastric bypass, and we should take care of them in the near future. I don't know if all of redos that we're doing, because we failed. I'm sorry about that, but I think we failed. Patients, they can go a suboptimal clinical response or with recurrence. It means that the patient is regaining weight, or they didn't do as we expected before. And I have to tell you that every time a patient comes to me and they didn't do right, I feel that I failed. It doesn't mind that I'm gonna throw things. No, I'm gonna stand up again and I'm gonna do what I think I need to do to offer to my patients the best. And they're gonna do the best to overcome all the hitbacks that we have. But to me, it's a failure. But it's not the last. We will stand up and we will do what we have to do. So I'm not going to talk about Roux-en-Y gastric bypass when we have a nutritional issue, when we have a recurrent marginal ulcer, when we have hypoglycemia, hyperinsulinemic hypoglycemia or dumping syndrome. Those are revisions that should take our Roux-en-Y gastric bypass to normal anatomy. That's what I think. We're going to focus on what happens once our patients, they don't lose enough weight or they regain weight. So we need to look at different things. The anatomy, what we've done, the behavior of the patients, that they're grazing, they're having snacking, they are binge eaters. What's the biology, how the microbiome changed, how the good hormones behave, and what's the context of the patient. Maybe the patient get really stressed and now is sitting at a different weight, or he has to pay for affordable food, and the affordable food is not food, it's edible things. So it's food that you can pay very cheap, but it's not real food, because the real food is more expensive. Unfortunately, if you want to eat healthier, you have to pay more money. And not everyone is able to afford that kind of food. So that's one of the reasons to go back and gain weight. And what we should do? Well, it was very well explained. We need a lot of things, and probably we have to be more cautious than we did at the first time we assessed this patient. EGD, mandatory. We need to check the pouch. We need to check the diameter of the anastomosis. We need to see if there's a marginal ulcer. We need to see if there's a fistula, if there's a bile pooling. Bile shouldn't be there if we're talking about the Roux-en-Y gastric bypass. What about CT? I love CTs. CT to me is mandatory in these patients. Why? Because the patient comes to you and they say, I did a room-wide gastric bypass somewhere else. I don't have reports. And then you're going to decide to do any other surgery to the patient after studying everything. And then when you go back, you realize that there's no remnant there. If you do CT scan, you know that the remnant was there, or it wasn't there. So it can condition what you're going to offer to your patients. Operative records, unfortunately, not always. We have the luxury of having them, and we don't have the luxury that the patient, the previous surgeon counted the bowel and reflected that in a discharge summary, for example. How's the metabolic review? Of course, the patient has to go to endocrinology and see how's his diabetes or blood pressure, how the medication is taken, or he's taking psychiatrist medications that help him to, or help her to gain weight. And how is the nutritional support? Is having any issues with the nutrition, with the vitamins? So we can find many things. We can find the gastric fistula. It's very nice to look at that, but how many patients did you find in your life with the gastric fistula? Very low, very little, very little. Candy cane is beautiful, that thing. Do you really believe, or ask me, do you believe that candy cane is one of the reasons weight regain? No, not really, but it's nice in a presentation. So you can go and chop it, but I don't think you're gonna gain anything. And about the size of the pouch and the size of the gastrojejunal anastomosis, does it matter? Well, people, they say that yes. And once we have all the studies, we can offer our patients for the weight regain, we can offer different things. From the minor thing, we can go back to the basics, eat better, do more exercise, give some medications. Probably these with the GLPs are gonna change. Definitely that's gonna change. Or we can offer a TOR, a transoral outlet reduction, or we can do a resizing of the pouch, or we can do a distalization of the room-wide gastric bypass, or we can do something more aggressive. But of course, we need to balance what's the benefit and what's the risk of these things. That's very academic, what I'm telling you right now. And what's the algorithm? The algorithm is, forgetting about the complication thing, is dilated the pouch? We have a wide J-junction. Okay, we can think about the TOR with the argon plasma treatment, or we can do application endoscopically, or we can redo the pouch surgically, or we can do something else. Or if the anatomy is intact, we can offer distalization, or we can optimize again the medical treatment. Those kind of stuff. That's why we have these papers about 50 cases of endostitch to reduce the connection between the pouch and the jejunum, right? They claim that if you only interrupted stitches and you closer, it works less than if you do a purse string. That's the definition of this. But the real thing, is the dilation of the pouch and dilation of the anastomosis the reason, or is the consequence of behaviors of the patient? We don't know, right? The patients are doing good. Maybe we can stitch that, but I can tell you many years ago, you can stitch the mouth and you're gonna have a good outcomes as well. Very uncomfortable for the patient, but stitching this down the line, you're stitching the same like the mouth. You're trying to restrict something, and you don't know if that's the reason. Those are the TOR publication, Giripenjo, in 2020. And you see the outcomes, okay? You look at the total weight loss after 5 years is 8.8%. It's not bad, considering that the risk of this procedure is not that complicated. But, well, if you dig a bit in the paper, you realize that the follow-up after 5 years is less than 30%. What happened with the other 70%? You don't know. And from the 3rd year to the 5th, the patients were taking medications. I don't know which ones. So it's a combination of things. So is it the TOR, or is the medication, or the patient decides to change? Well, what's the influence of the pouch and the anastomosis? This is a paper from Cleveland Clinic saying at the end of the day that it matters. Those patients that had a bigger pouch, those patients that had a bigger anastomosis had more prone to regain weight. Interesting, but is the cause or is the consequence of the behavior of the patients? Did they eat more the way they were eating? It was dilated. Yes, it's dilated. They gain more weight, but is that the reason? Well, some people thought that it was true, so they went and did 5-6 patients redoing an anastomosis. To me, this is not an easy surgery. To redo an anastomosis in a room-wide gastric bypass that regain weight, is not an easy thing. And again, if you had at the first surgery the same outcomes, why do you repeat it? You can go farther and you can invent the wheel and add a band that we all stop doing. Of course it's gonna work. Again, if you restrict, that's gonna work, and it works after 24 months. So what is there any issue with that? I think the cables, yeah. So it makes sense to do something with the pouch is dilated. There's some, so there are some issues with the pouch. It makes sense that you can do that, but if the pouch is normal, don't try to do anything. Distalization, if you're gonna distalize a patient, which is in lengthen the BP limb, so it's shortening the alimentary limb, we should look at this paper from Calvin Higa. They did 96 patients or something like that. In the first 11 patients, the toll, which is the length of the alimentary limb, it was less than 3 meters. They have to reverse 9 out of 11, and moved from 11, they moved to 400 or 450 toll. So once you measure everything, be sure there's no signal. You lost my, no, I think it's something there. Yeah, don't touch, don't move. Don't move. So this paper is saying that if you're gonna do a distalization, please, your alimentary limb, which is the sum of the root limb and the common channel, shouldn't be less than 4 meters. That is gonna be a safer thing. And this is more or less what you have to look at. So again, the root limb and the common channel should be no less than 400 centimeters, okay? So, and we can go farther and do more aggressive surgeries, which is a BPDDS or SADIS. And I like all the things that I told you right now, but that's very academic. Do I believe it? No. So I think first, when we're talking about, is the patient being cheating, is grazing, is the pouch bigger, is the behavior, why didn't we assess this before at the first surgery? Why didn't we do that? So to me, and I know that Javed has a different view about that. To me, if I have a surgery in my hand, I will offer to my patients. Otherwise, I will not offer even the first one. So what I need to know is do something different. Do something different. And now, because we have another surgeries, and that's what I'm saying, I review and I revise the patient from the room Y to the transit bed partition. Why? Because it's a different concept. It's a new concept. It's like a GLP treatment for the patients with one shot, and it's independent of the patient wants or not. When he eats, stimulates and triggers the ileum. This is a 7-minute video. I don't know how much. Okay, so this is the surgery. First, I measure. I'm not going to touch it because I don't know how to move it. So counting the bowel is critical. Marking the bowel is critical not to make mistakes. Even when you come back one day because you have to repair it on the patient, you can measure again and you can realize how good, bad you were at the same time, or how the hypertrophy of the bowel make it shorter. So counting is very important to know where we're going to place our anastomosis. I don't know if this is going to be a 3 meters. I wish I could advance it so you don't get sleepy. This is 3 meters. We place the liver retractor. I'm going to try to think what the Dr. Matt is doing with the liver. I got like a heart attack when you do that, but split omentum. Then I need to release adhesions from the pouch. We use a ligature or whatever energy you have. Clips, remember the clips. We resect the previous anastomosis, so we have the pouch there. Then we're going to remove the remnant because we do have a remnant. So now we're going to start to dissecting the greater curvature like we're doing a sleeve gastrectomy. I do it twice. As you can see, I do once and I do the twice. Do you need to do it? No, I sleep better. Do I have any science behind that? No, but that's the way I do it. And I'm going to do, this is like a sleeve gastrectomy in the remnant part. We're going to dissect upwards close to the left pillar that has to be exposed all the time. And then you will see that in this case, I'm not going to see that we have a gastrogastric fistula, but when I realize the pouch with the upper part of the remnant, it's a bunch of staplers, so I prefer to use and divide it with a new stapler to avoid any complication. Then I resect the fundus first, and I do the first gastrogastric anastomosis. I do this with a V-lock. This is the first layer. Then I open the stomach. I want a wide anastomosis. I don't want nothing narrow. So I'm going to use probably the whole, almost the whole pouch. I open the gastric remnant, the distal part, and I'm going to do the anastomosis. I do 2 posterior, 2 anterior. I don't know why I did this. I don't know if it's no. This is a V-lock. Usually I do a PDS, but I don't know why I'm doing a V-lock with this one. Probably to be faster. So this is the first. Too much coffee. So this is the gastrogastric anastomosis. So now we need to complete our sleeve. Now when I have my anatomy, then I do the sleeve and I complete the sleeve, because now I see how my pouch is, the blood supply is perfect, so I can do the sleeve gastrectomy. Then I have the remnant there, and I can do my second external layer, the second one, to make it prettier. Do you need it? Probably not. Probably not. I'm gonna keep doing that? Probably yes. So now I can open the bowel, the enterotomy, and I can open enterotomy in the stomach. Yesterday I showed you a Hansun, and this one I'm gonna do a linear stapler with a blue one, and then I'm gonna close the defect with a, I don't know, B-lock or PDS, bar suture, to make it faster. I always go a bit beyond the anastomosis. Then I'm going to resect the ruling. After measuring, if you have enough, you can resect it. You're talking about 70, 80 centimeters. Of course, if you don't have enough, you have to use it. But in this case, I decided to remove it because we had more than 5 meters, so I didn't think that any problem. I remove it, and then I'm going to do again, and you saw that before. I'm going to do the end to side anastomosis. This was with one anterior, so you saw that yesterday. Of course, I will close the defects, and we can go finishing this presentation because you are really tired. So those are the conclusions. Where regain is an adequate initial weight loss are a fact in bariatric surgery. So we need to set reasonable expectations to our patients beforehand, and it's really important. Multidisciplinary teams are essential for better outcomes, since a medical, psychological, and surgical approach are the therapeutic options. Surgical treatment is complex and rate of complications is higher than primary surgery, so be sure that you have the skills, the support to accomplish it. If don't, ask for help. It's okay to ask for help. And new metabolic procedures like bipartitions open a new approach for revisional surgeries. Those are the references that we have, and thank you very much for your attention.
Thank you so much, Dr. Carlos.